Next session is probably be one of my favorites, and that is ophthalmic consolidation. Every industry is consolidating now in the United States. And what does ophthalmic consolidation mean to you? We're going to hear from a variety of different people about the effect of consolidation, and we're going to have our moderator come up first, Kerry Solomon, who will take us through this next session. I'm really looking forward to it. Kerry.
Thank you very much, Eric and Jim and Gil, on behalf of the organization. Thank you for allowing us to have this session. You know, it is an interesting time, and we've heard lots of discussion and comments about the recent pandemic and COVID-19, and certainly it's wonderful to be back together and to be live. You know, Dr. Lindstrom just mentioned how ophthalmology is different, and that's absolutely the case. We think we are more collegial. We think that in many ways our interaction with industry is probably second to none. And we've had a very stable relationship amongst ourselves, our peer group, our mentors, our teaching hospitals, and industry for many, many years, which has, I think, been the engine, if you will, to so much innovation. But you know, times are changing. And as Eric said, things are consolidating. And the real question which falls on many of us is, how do we fit into all this? What does that mean? And I'm thrilled that we have a terrific and very esteemed panel with us today. I'm going to go around for maybe a minute each or so and let each of our panelists introduce themselves. Let's start here with Rick.
Thank you very much. Happy to be here. This is such a great event, and as has been said before, I want to echo, it's great to be here in person. Rick Gannotta. I've been in healthcare 40 years. 20 of those years I've had the great honor and privilege of serving in the C-suite as either CEO or COO of institutions like University of California, Irvine, Northwestern, Duke, Raleigh Hospital, and Wake. So I have had a great career. Most of those institutions, obviously, were leading research organizations that had a very, very important eye program, ophthalmology being one of them. So thanks.
Thank you, Rick. And what Rick left out of his introduction is he actually did some training in Charleston at the Medical University of South Carolina, so This is clearly an expert. Please, Ruth.
Ruth Williams, and I'm a glaucoma specialist at the Wheaton Eye Clinic. I'm CEO Emeritus of the group. We have about 33, 34 ophthalmologists and 15 or so optometrists. And we opened our 6th full-service location in the middle of the pandemic. And I love private practice. We're still independent. And I think it's just an incredible place for ophthalmologists to have a career and take care of our patients.
Wonderful. Anthony Hayes.
Hey guys, I'm Anthony Hayes. Good to have everyone in person, and thanks for hosting this. I'm an investor at Revelstoke Capital Partners. We are a healthcare services private equity firm based in Denver, Colorado. So we focus only on healthcare and specifically provider-led multi-site businesses. We've been invested in ophthalmology through our partnership with Cincinnati Eye Institute. Our management services organization is called CVP. We've been invested with them for about 3 years. We just eclipsed about 110 doctors in our group across a couple different states, so have gotten a lot of traction and scale and in our own little consolidation across the country, but happy to be with you guys and excited to be here.
And Joel Brill.
Kerry, thanks so much for the invitation to be here. Folks, I'm a gastroenterologist. I'm not used to looking at you eye to eye. So my background, I've been a CPT advisor for a quarter of a century. I brought through close to 200 CPT and HCPCS codes. I was in the RUC. I was the vice chair of the RUC's practice expense subcommittee for 4 years' time. Been a health plan medical director, Blue Shield of California, Foundation Health, ProCare/Aetna, and Charity United Healthcare Scientific Advisory Board for 4 years' time. And within other fields, I've done a lot of work with both investors, private equity, healthcare lawyers, and like. So pleasure to be here in real life.
Thank you very much, Joel. I know when we put the invitation out, you thought this was the Association of Colorectal Surgeons, So I'm glad we could clear that up for you. Okay, so my first question really is, there's been a great deal of consolidation in healthcare. And so with regards to ophthalmology, how do each of you anticipate your role with consolidation, perhaps in the next 5 years? And specifically for our folks in the audience, physicians and industry, what would your advice be? Let's start with Joel.
Well, I think there's some things that are really clear. First off, cost pressures. On the physician side, Medicare's fee schedule is designed to become budget neutral. And if any of you looked at what Medicare did last week, Medicare increased the expenses for your staff in your office setting. And in order to become budget neutral, what did that mean? It means that the reimbursement for services in your office setting, if you've got a device-intensive procedure, just went down. Okay, so what does that then mean? Well, you've got to look at ancillaries. You know, are you doing infusion services? Are you doing an ASC? Things of that nature. And it's becoming very, very hard for smaller groups to be able to keep up with these pressures. When you're contracting with large groups, when you're contracting with health systems, when you're contracting with payers, they want to know data. And if you don't have data and you don't know your cost structure and the like, you have few options. And I think this whole cost is at the core of why there's consolidation.
Mr. Hayes, same question, but specifically, why is PE interested in ophthalmology?
Yeah, it's a good question. I think private equity is really focused on trying to be in the right area of the cost containment curve, and ophthalmology has taken a lot of steps. Obviously, ophthalmology has a lot of ASC utilization in the US, which is taking costs out of the system. There's a lot of ancillary services. You know, some groups are single specialty, then we are more focused on multi-specialty groups that obviously benefit from the internal referrals from different types of subspecialists. So I think there's just a lot of spend, you know, all of the macro trends of 18,000 ophthalmologists every year, but more and more demand for the services. There's a lot of different ancillary services as well. So for us, it's just putting money in an area that's growing organically. And then to your point earlier, I do think there's a lot of benefits of scale, especially regional scale. Healthcare is very local, and getting leverage against the payers and really trying to innovate and do things that are outside of just performing more cases and increasing volume, I think is where the money is going in the sector, and I think that that'll continue to happen. And then there's a whole nother case to be made about national consolidation of groups like ours, for instance, and then vertical integration where people are really doing kind of optical retail all the way through the medical surgical ophthalmic services. And so, you know, that's another area that we've seen a lot of people put money into consolidation as well in the private equity space.
Thank you. Rick, same question, why consolidate? And specifically in the past, hospitals have pretty much ignored or stayed away from ophthalmology. What's different?
It's a great question for all of us, I think, and obviously different perspectives. I would say if you take a look at the last 5 years with hospital and health system consolidation, it really has been because of declining reimbursement. There's no doubt about that. Low margin hospitals, if the average hospital was looking at, say, a 2.5% margin across the board, these downward pressures were pretty tough. So that really was something that has existed. The pandemic accelerated a lot of things. I want to break this down into a couple points here. One is, I think the consolidation and the acceleration of that has increased. So what you're seeing is the regionalization and the super regionals, in fact, either whether they're religious institutions or hospitals like Providence, St. Joe's, et cetera, coming together. This is happening. The country isn't in lockstep, right? So what's happening on the East Coast and the West Coast could be out of sync slightly, but that continues, and it is happening because of reimbursement issues. Now, the second piece is what I say is more of an emerging trend, and that's where you're seeing the Walmart coming in, Amazon, et cetera. They're looking at new models of care, again, accelerated because of the pandemic. It's not a disruption, it's an acceleration. We heard a little bit about this earlier. These new models of care, probably in the telemedicine front, et cetera, will drive further consolidation, perhaps in a different way. Now, when you look at hospitals and health systems and their relationship to ophthalmology, I would say this, it probably is getting much more favorable, much quicker. Why? Because I think that if you just take a look at 65-year-old population, over the next 10 to 15 years, that group will grow by 50%. If you look at eye care in general, probably consume eye services about 10x versus younger patients. If you look at where reimbursement is, although it's tight, ambulatory services, always attractive. This is a good combination and good calculus to have. If you marry that to centers of excellence and other specialties like ENT, dermatology, trauma, reconstruction, et cetera, ophthalmology is indispensable in that calculus. So I think that is, in general, why you're having a more favorable approach from hospital executives to eye centers, centers of excellence, et cetera, that revolve around eye care and ophthalmology.
Thank you. So, Dr. Williams, same question. What are your thoughts about consolidation? And I know you've mentioned that you're consolidating a little bit on your own. Tell us about that.
Yeah, well, our own practice hasn't consolidated so much as that we've had an organic internal growth strategy. So we grow by adding about 3 physicians a year and opening a new office every few years. And so it's a different model. We've looked at consolidation through merging practices, but as most of you in the room know, that can be very challenging when you have different structures, different ownership structures, different cultures to bring together. I think a lot of ophthalmology practices have assumed that bigger is better and are trying to bring their groups together. So our strategy has been a little bit different, and it's worked very well. But we do think that as hospital systems and private equity groups grow, that our hegemony in a certain footprint will decrease. So in the past, we would have we would control most of the ophthalmology in our footprint, and we recognize that that will shrink a little bit over time, and so we want to be in more different places. And so a result of consolidation is that we're spreading out.
Your response is you're going to grow yourself in
Correct.
preparation for when consolidation happens around you.
Well, it's our response to the consolidating
consolidation.
marketplace.
Understood. Dr. Brill, what's your advice to folks in private practice and industry as they ponder their future in terms of consolidation?
Well, a couple things. First thing is the 4-hour rule. The 4-hour rule is whoever you purchase or consolidate with, can you drive there within 4, maybe 5 hours? Because if you have to solve problems at a national level, are you going to get in an airplane every day? You're going to fly from Vegas to Seattle, and then the next day to Charleston, and the next day to Chicago. And that's really challenging. But if you look at your neighborhood and you look at that 4 or 5 hour rule, if there's a problem that occurs, if it's a whatever problem, you can solve it, you can get in a car and you can drive there. Now, why is that important? Because the cost pressures are immense, okay? Ophthalmology came out flat. You didn't take any hits, you didn't take any losses in the 2022 fee schedule. But you've taken some significant losses in the last few years in cataract surgery and the like. You've seen some of your procedures, for example, in the proposed rule, okay, where reimbursement's cut. You're seeing ASC reimbursement for new procedures being cut. You have challenges to infusion services with Eylea, Lucentis, and you've got on the other hand a plan is saying, I can use repackaged Avastin or Mavasi for less than $50. Okay, so you've got to start thinking now about the fact that you have to have data. If you're negotiating with a hospital, if you're negotiating with a plan and the like, you have to have data. You have to be able to use your data to show how you're effective, how you're efficient, how you drive high quality services, because you have to look at the fact, and I think the point that's already been made, multiple services under one roof, and also the fact that you've got consumer-driven services, not just insurance-driven services, is a very important factor to your success and your ability to thrive, not just survive.
Thank you. Mr. Hayes, what's different this time? There's been consolidation in the past that's failed, so there are people sitting outside, sitting here in the audience saying, maybe I'm interested, but I'm not so sure this is going to make it? What's different? We've been here before.
Yeah, it's a great question, and one that we obviously get quite a bit. Look, I think previously people were much more focused on quarterly earnings and cutting costs and just kind of cramming a bunch of groups together purely for the fact of gaining scale, as was said earlier. And from our perspective, and I can't speak for all of private equity, but the right private equity partners are much more focused on preserving the culture and the clinical quality and the outcomes, and then really focusing more on investing into the practice and being able to get the data and being able to kind of take that next step as everything shifts towards risk-based and quote-unquote value-based care, whatever that means. And so, I do think that if you partner with the right person, they'll be much more focused on accelerating growth and a lot less focused on just cutting costs to hit earnings targets. And so for us, our kind of thesis or strategy in the sector is really around quality, value, and access. Is the quality of the care going to be diluted with the group or the groups that you're contracting with or partnering with? Is the value of the service, good for both patients and payers? And obviously the providers need to be in a place that they like to work. And then access, just providing more and more access to these services. Obviously rural healthcare is a problem in the United States, and I do think that this, allows us to continue to grow density in regions that give access to some people in those markets. But those are kind of how we think about the consolidation now.
Awesome. Dr. Williams, should the societies, AAO and ASCRS, should they be doing more to assist private practices, and if so, what?
Well, the whole mission of ASCRS and the Academy is to support the practice of ophthalmology, which includes private practice. So I think there's always more to be done, and I would say maybe not do more, but shift into meeting the needs of the 21st century ophthalmologist. So what our organizations do will change over time. At our recent Academy retreat, we talked about the shortage that we're all experiencing and trained ophthalmic technicians. So every private practitioner you talk to groans the same groan about that issue. So what the issue is and what the organization comes alongside to help us, I think will change over time.
Great. Let's move on to another topic that I think we all sort of alluded to, which is it's getting more and more challenging to run our practices, especially as it relates to third-party payers. We've got reimbursement cuts that happen almost every year, yet our overhead doesn't go down whatsoever. Recently, I think it was Aetna that now requires pre-certification for cataract starting this past July. The Academy and ASCRS have estimated about 20,000 people will be affected in July alone. And this is another burden, if you will, on many of the practices to go through all these pre-certifications. Dr. Brill, what would you recommend or suggest for our audience to help manage some of these challenges?
Pre-certification, whether it's pre-certification of cataracts or pre-certification of wet AMD treatment or pre-certification of gene therapy, costs money. And so I would be looking at, and I hate to be saying, what's the dollar bill say, in God we trust, all others bring data, but bringing data is so important, because if you can show that you do services that are reasonable, necessary, in accordance with either Medicare guidelines or a commercial insurer's guidelines, and you can show them their data that they're not having to deny what you do, you may be able to negotiate away on a group level the need for pre-certification, because you're showing that you're delivering a high quality service. Just so you have an idea, if you submit a pre-cert to a health plan, it costs them almost $250 when everything is said and done. So if you take your 20,000 Aetna cases last month and you do the math, that is not an insignificant chunk of change. And if you can think about things in the way that value-based, whatever that means, quote unquote, care is becoming, and you can present data that shows that you do high quality services, reasonable services, and appropriate services, you may be able to negotiate away and get out of those pre-cert requirements. And again, it comes back to, why do people partner with private equity? Because we're not trained in medical school to think this way, okay? But we need business people who can think this way and can talk the language of both the payers and the health systems who do think this way, so that we can show that we're valuable partners.
Thank you. Mr. Hayes, so I'm a private practitioner. Are there advantages or benefits for me if I were to join private equity to help manage some of these future challenges, ongoing reimbursement cuts, et cetera? Can you guys help? And if so, how?
Yeah, like I think in healthcare, changes to regulations or changes to reimbursement are not new. They're not going to go away. It's going to continue, and it's going to be continually hard to make a living in medicine, unfortunately, which is kind of a unbelievable thing to say, but I do think it is going to continue to be that trend. Does private equity or health systems or insurance companies or anyone have a magic bullet? No, or else we wouldn't be sitting here. We'd be on some other crazy island and never work again. But what I do think that we can do is it really boils down in my mind to like 3 basic things that you need to be able to do in order to combat it and have the conversations and be at the table. The first, which you've hit on every single question, is data, and data is very important, whether that be patient satisfaction, cost data, outcomes data, quality data. All of that is really important, and in healthcare generally, it's not very good, especially with smaller groups that just don't have the time or the dollars to invest in the infrastructure and the technology to have that data. So I think that's kind of table stakes. The second, in my mind, is really moving, and this is an easy one, but moving as much as you can to as low of a cost care setting as possible. So shifting anything and everything that's eligible and medically able to be out of the hospital and HOPD settings into surgery centers and even clinics is where things are going to continue to go. The payers are pushing it, Medicare's pushing it, everyone's pushing it that way. So being ahead of the curve will buy you some time, but won't ultimately solve the problem. And then last is really figuring out and trying to stay ahead of the value-based or the risk-based contracting, because that is coming. I don't think anyone in this room or anyone anywhere really knows what that means specifically for ophthalmology, but if you don't have the data and you're not already doing everything you can to take costs out of the system, you're not going to be able to be successful at that. So I think the only advantage to partnering with private equity or continuing to be private or even partnering with a health system is having the access to capital in order to make those investments and not do personal guarantees that the doctors have had to do since they've been founded. So
Dr. Gannotta, hospitals, how do they plan to manage reimbursement? Is it any different than what we just heard from Mr. Hayes?
Well, I would say this, just kind of tagging on to what was said. I think there is a benefit for when you think about ophthalmologists joining health systems and institutions, and the number one benefit is contracting. There is a world of difference between 110% of Medicare and 210% of Medicare. And you see that at big practices, big institutions, health systems that have the kind of relationships that allow them to get around and leverage the data and leverage their scale to twist the arm of Aetna, now along with society, et cetera. So I would say that. But in general, the reimbursement issue, I think, is one that I've contended with in my career every year, year over year, since it started. And I don't see it going away. I think when you take a look at what the strategies have always been in, it is to peg your costs down to Medicare rates. Is that real? I mean, but I don't know, but that's something that at every institution I've been at, we've tried to do. The other side is look at your fixed variable costs, see if you could scale things so that you reduce overhead, and of course then at power of the number that gives you the scale to negotiate with commercial insurers, really get them to comply with where you want to be from a percentage basis. The modes and methods have not changed. I think they have stood. Unfortunately, reimbursement continues to be ratcheted down.
Dr. Williams, you just heard from everyone on the panel regarding consolidation and their strategies. So in private practice, what recommendations can you give our private practitioners for how to best manage reimbursement cuts, challenges with third-party payers, et cetera?
Well, we were talking about a little bit about contracting. This is just very practical advice. We hired someone from a hospital contracting experience and had him come and do all our contracts for us. And we had an independent group come and look at our surgery center, because they were interested in buying it, and they looked at our contracts and said, oh my gosh, we can't do better than this. So, we hired the help to do what we're talking about. Is that sustainable long term? We'll see, but because we're experiencing that downward pressure that we're talking about. But, I'd say one more thing about ophthalmologists. It's a pretty smart crowd, and if you have ophthalmologists who are interested in learning the business, they can do a very good job. The question is, can we train up people, or do people have the interest to do that kind of work and learn that language?
Last follow-up question, 30 seconds for each of you given our time. As we're consolidating or we're growing, whatever we're doing in response to these changes, should industry be dealing with us differently as a larger group, as a health system in a private equities form, compared to the way relationships have occurred now? And if so, what should they be doing different?
I would say this with respect to industry. I think we could take a lesson from the pandemic and looking at public-private partnerships. We wouldn't have had the vaccines if it wasn't for industry. We wouldn't have had innovation if it wasn't for industry. Obviously, clinicians are the other half of that equation. And this is obviously no disrespect to public institutions, but I really think the innovation in the private sector is going to drive and hopefully be the thing that keeps us going in the right direction. So partnering is absolutely the way to go.
Great.
I love partnership, which is why I'm here at this meeting. I think this innovation meetings are probably the most interesting of the year. Ophthalmologists, I'm speaking as a clinician, we get so much out of industry because you think differently than we do and attack a problem with a different set of eyes. And I appreciate the collaboration, and I think ophthalmologists need to understand how you think.
Mr. Hayes?
Two things. I think one, that the continued consolidation in whichever form it is will at least force the conversation at earlier points in people's careers, so that, to your point, when you learn how to become a doctor clinically, you can also understand the business of becoming a doctor and kind of what all of that entails, and choose your own destiny. And then I think, from just touching on the payer side one more time, I think orthopedics does this better than ophthalmology, but what we need to start doing is shifting the conversation from give me 2% rate higher, give me 135% of Medicare, this or that, and shift it more into like, we are saving you money by quality outcomes, less readmissions, moving everything we can to the lowest cost care setting, and shift almost to a shared savings model, which has worked really well in orthopedics, and I think is a little bit of a mindset shift for the industry that I think would be beneficial for everyone, including the payers.
Great. Joel?
Simple answer. There's great opportunity in collaboration.
Wonderful. You guys have been great. How about a round of applause for our panel? Thank you. That ends.
Great session.